afternoon, everyone. Thank you for joining us this afternoon for our last caucus of the 2008 season. Before I introduce our speaker today, I want to acknowledge our Congressional Biomedical Research co-chairs, and that would be Congresswoman Lois Capps, she's from California, Rush Holt from New Jersey, our Republican co-chairs, Congressman Brian Bilbray from California, and Mike Castle from Delaware. They've been phenomenal this year. We've had a great season with a lot of fantastic speakers. So I just want to thank them for another successful season. And today is definitely a great speaker in front of us. I don't often, well, actually I do often get a chance to introduce what I think are geniuses, but this one has actually been acknowledged as a genius by the MacArthur Foundation. Newly minted yesterday, and unlike other awards that recognize a lifetime of achievement, this fellowship are given to people at pivotal points in their career based on their potential. So Dr. Peter Provonost, also a Time Magazine 100 Most Influential People of 2008, has been described as a scientist who has saved more lives than any laboratory scientist in the past decade by relying on a wonderfully simple tool, a checklist. His checklist has saved the state of Michigan more than $100 million in over 1,500 lives over an 18-month period. He is a practicing anesthesiologist and intensive care physician at the Johns Hopkins Hospital and a professor in the School of Medicine and the School of Public Health at Johns Hopkins. He is a trained researcher involved in national and international efforts to improve the delivery of health care. So with that, will you welcome Dr. Provonost?
Thank you. So I plan to talk for probably about 15 or 20 minutes, and then we'll have plenty of time for questions. And I appreciate you taking your time out of the day with all that's going on. To highlight some of the relevancy of the real crises that we're facing in our financial markets today, share with you, I recently got back from speaking to the executives at Barclays Wealth Management, where I dissected the financial crisis like I would a medical error, or like I would any disaster that happened in a health system. How would I go in and think about root causes? And you all are reeling with this, the idea that the root cause is having some distressed assets on our books, and how we're going to do that. And I'll posit to that, I think that's missing the boat, that the fundamental root cause of many of the failures in banking are the exact same as the failures we're facing in our U.S. healthcare system, and that is we have an incredibly inefficient knowledge market. An incredibly inefficient knowledge market. It's not that the knowledge isn't out there in the community, it's just that those making the decisions are making bad decisions because they don't have all the information needed. So the consumer who's buying a mortgage that is more than their monthly income is just making a bad decision because someone's selling them a bill of goods. That if they had, I'll posit a checklist that can say, what would a wise person do? My help, right? Or the investment bank who's buying these goods, who, if they had the knowledge to say, okay, there's secretaries in Baltimore who think they're becoming real estate moguls by buying real estate, that's what you're banking it on, may not make a better decision. Or the poor patient who comes to the hospital who's trying to get the best care for diabetes or heart disease, but doesn't get the right therapy at least half the time. We have to make these markets more efficient, and hopefully I will make this relevant to some of the stressors that you're facing right now in a broader perspective. This picture is a test that's called a functional MRI. It's a test of blood flow in the brain. It is unfortunately the MRI of a budding surgeon. This young woman, a surgeon in training, went home after working one night and woke up with tingling in her hands and slurred speech, and went and got a CAT scan that showed that she had a rather nasty tumor in her brain. And obviously being worried about that the surgery would destroy the use of her hands and thus her career, the doctors did this test called a functional MRI, which measured her blood flow while she curled her hand. And what the orange part is the part of her brain that's active, and that kind of white spot is that ugly tumor. And what they found is that where they planned to cut was part of her brain that controls the use of her hands, and she would have destroyed her career. So they cut through a larger part of brain, but that is less active, and she woke up with no deficits. I mean, it's a remarkable, remarkable example of the advances in biomedical science that the U.S. public has achieved. Indeed, the U.S. is the envy of the world in advances in biomedical science. As you probably know, AIDS is now a chronic disease. Virtually all childhood leukemias are curable. The life expectancy since the late 50s has gone from 65 to 78 years old. And truly, we are the envy of the world for advances. And yet, that same health system that saved this woman's life can't stop leaving sponges in people when they operate, right? That's a sponge in someone's belly. And when I think about this, and I think the public thinks about it, you say, help me reconcile these two seemingly disparate pictures of biomedical science in the U.S., because at one we're held up as the pinnacle, and indeed I think we are, and in the other, the estimates are that we kill 98,000 people a year, that you or your spouses or the U.S. public, when they go to get health care in this country, could count on getting the evidence that you're supposed to half the time. That's a deplorable statistic. And we are ranked dead last among the 30 countries of the OECD in terms of quality of care, costs, and access. And so where does this disparate picture come from? And I'll posit to you, and your role is so critical in this, that where it comes is that we have a glaring gap in this translation superhighway of going from basic research to improved health that needs to be fundamentally addressed. And let me walk you through this model for a second. If we think about biomedical discovery, much of it's funded by NIH and other agencies under HHS, that we begin by understanding disease biology. So that's all the basic science, finding new genes, you could think of it as. And then some of those work, and we look to translate those into humans. So we start testing and see, could some of these therapies work? We then identify, and now hopefully with this new institute, compare therapies that work. So we find, okay, this works in this disease, should we start use it? We then ideally would translate those findings into clinical practice, and then look, how do we implement those? How do we sustain those? And ultimately, we have improved health. Right? So that's kind of this knowledge dissemination, or you can think of it as a knowledge market. Well, what do we have? Well, unfortunately, that T2 in implementation, the part of the world that I live in mostly, isn't viewed as science. NIH virtually doesn't fund that. Their view of the world is science is finding new genes and science is finding new drugs, and how the public uses those is the art of medicine. The Agency for Healthcare Research and Quality kind of has ownership of those last two things, but it is woefully underfunded. Indeed, we spend a penny for putting things into practice for every dollar that we say we spend finding new drugs and new genes. So we have this market, if you think of this knowledge market, that is incredibly inefficient. We know a whole bunch of what works, and we need to keep learning more. I'm not saying we don't need to keep supporting those investments, because we absolutely do, but it's not being put into practice. Let me give you a concrete example in the world that I live in. So over the last 40 years, the NIH has funded, it was hard to find the total amounts, but hundreds of millions of dollars in a disease that's called acute lung injury. It's an injury that happens to our lungs that has a 40% mortality. So 4 out of 10 people who get it will die. And they funded a lot of basic research and 25 different large trials on therapies. And the net output of that was, what they found was that one therapy could reduce your mortality from 40% down to 30%. So it's not the holy grail, but it's a 10% reduction in mortality. And it involves a really simple thing, giving people on breathing machines smaller breaths. That we found we were giving them too big of breaths, and the treatment was actually causing more injury, that if we gave them baby breaths and allowed their lungs to heal, they had a lower mortality. And despite all that research, half of the patients in this country get that therapy, even at the places that were funded by the NIH to do this study. And what is the mission now? Well, we're going on to find new therapies. And you would think the taxpayers would say, okay, time out, we found something, don't we have to make this highway work? I mean, the end game can't just be new knowledge. The end game has to be health of the population. But there's not coordinated efforts to say, okay, we found this, now, even if it's handed it off to another agencies, what's that efficient market to say, okay, we found this thing, we spent a lot of taxpayer money on it, it's not okay just to find that we have new knowledge. We have to make sure it gets put into practice, but there's no connections there. So indeed, we submitted grants to say, okay, let's put it into practice, but it's not really NIH's purview. ARC has no budget, and thousands of people die a year because of that. I got very personally involved in this from speaking to the mother of this little girl. This is Josie King. Josie was a little 18-month-old who ironically was born about the same time as my daughter was, who died at Johns Hopkins from completely preventable mistakes. Completely preventable mistakes from, you could argue, an inefficient knowledge market. And on the 4-year anniversary of this little girl's death, her mother came to me and said, could you tell me 4 years later that Josie's less likely to die at your hospital? And I started telling her all the stuff we're doing. So we have this program and that. And the mother abruptly cut me off, and appropriately, and said, Peter, I didn't ask what you're doing. I asked, could you tell me you're safer, and how do you know? And the reality is I couldn't give her an answer. No hospital in this country can give her an answer. And I think fundamentally she deserves one. Now, there's been a lot of efforts. Many of you are probably aware of that Institute of Medicine report to Ur is Human that highlighted the shortcomings of quality in this country that was published in 1999. The National Healthcare Quality Report, it's an interagency report that comes out of HHS, categorized what we've kind of progress we made, and some may call it pathetic. It's certainly underwhelming. So in the last 10 years, for a variety of different things, we increased the extent to which we use evidence-based medicine by somewhere around 1 to 2 to 2.5%. So let me think about that. So that national statistic of doing what we're supposed to do half the time, we got it up to 52% of the time, right? I can tell you when we showed this to that little girl's mother, wasn't so impressed. Perhaps even more concerning is that when we looked at how we are measuring on patient outcomes, the main conclusion is we have no data, that we don't even know how to measure these things. We don't have an answer for that woman. And what we have shows we're not making so much progress. But it was striking for the paucity of data. And our disparities of healthcare, which again, as you know, is frankly a public scourge, are only getting worse over time. So our failure to view this as science is we're paying an awful big price for it. And we need to invest in it as science. As you know, in healthcare, obviously the economy, I think, has, and appropriately, has trumped on the elections the main issue. But in healthcare, the three big things are cost, quality, and access. And we're doing, frankly, miserable on those. And the problem is we've approached them all separately. So it's like my daughter making a balloon where you squeeze one end and it pops out the other, right? And where the insurers are squeezing on the docs push back on the regulators. And the reality is we need a sandbox to approach it scientifically. I have this approach, and again, it's the same thing that I think applies to this financial market. When I think about impacting a large market like finance or like healthcare, there's two axes that are two domains that I think of. One is kind of the technical or being scientifically sound. How do we get the science of this stuff right? And that's that horizontal axis. And we alternate between being scientifically sound and feasible. And we certainly can't be paralyzed by evidence, and we're always going to have incomplete evidence. But we're erring way on the side of feasible, and we're doing an awful lot of things that are unwise. Indeed, if I had to think of one metaphor, it would be like the drunk looking for his keys under the lamppost because that's where the light's shining, right? So even the data we collect is simply because there were systems to collect it. It's not what that girl's mother wants to know, am I safer? And we have to do the wider. And then that balance between kind of a regulated central mandate approach and free market local wisdom approach, we're way on the side of regulation, and we've paid an awful big price for that without reflecting into that local wisdom of the caregivers. And as all you know, there's this tension between the free market and regulation, and we predictably in healthcare and other things overshoot or undershoot. And I think our realization with Sarbanes-Oxley is an example of, yes, we need some regulation, but boy, we have to do it wise. And so what I'll put for you is, and I want to show you now an example of what happens when you're at that sweet spot in the middle, when you bring science to the delivery of care, the potential to save. So what did we do? Well, we had packaged a safety program at Johns Hopkins to eliminate one simple kind of health problem, and those are called catheter-related bloodstream infections. Those are infections that we give to people when they're hospitalized from putting catheters in their body. These are typical, like an IV catheter, tubes that go in their neck or their groin to give them medicines to monitor how their heart's working, and sometimes they get infected. Sometimes, just so you know, there's about 250,000 of those infections a year, about 28,000 deaths in the U.S. a year, and about $3 billion in excess healthcare costs attributed to these. And when people are sick or we have these harm, there's this tension to say, do these fall in the inevitable bucket? In other words, they're just the cost of doing business, or are they in the preventable bucket? Right? And I think, again, same analogy of the financial markets. Are these bad decisions just inevitable? You're always going to have them, or could we prevent them? Well, we didn't really know. But we did know that there was some simple evidence-based steps that docs weren't taking. So we went to our doctors at Johns Hopkins and said, okay, we made a checklist and said, we want to ensure that every patient gets the evidence on this checklist. And I don't want to debate with you whether these infections are preventable or inevitable. My gut says most are preventable, but until we always do what the evidence says, we don't have a clue. It's a mythical discussion. So let's create a system where patients always get the evidence and see how low the rates go. Now, why this checklist? Well, medicine, again, in this idea of an inefficient knowledge market, summarizes evidence in the form of practice guidelines. And you may even see we have guidelines.gov. And they're absolutely needed and elegant and scholarly, but they're completely useless at the bedside, right? They're 200 to 300 page documents with hundreds of conditional probabilities or if-then statements that are great for summarizing the evidence. And then they're a key step, but they can't be viewed as the output. So what did we do? Well, we literally sat around and said, no one's going to use this. Let me go through that and pick out the things, the 5 to 7 things, like a phone number, we can't remember more than that, that have the strongest evidence and have the lowest barriers to use. So there's no new technology needed. And let's see if we could make a checklist and get docs and nurses to use that. So the 5 things we picked were wash your hands, not rocket science, clean your skin with this soap called chlorhexidine. It reduces infections by 1/2 and costs no more than normal soap. Wear a cap, gown, and mask, so cover yourself and the patient when you're putting these in. Try not to put these catheters in the groin because it's dirty and they're getting infected. And if you don't need a catheter, take it out. So every day just ask, do I still need this? Am I getting value out of it? Right? We took a 100-page guideline to 5 things on a checklist. And we virtually eliminated these infections at Johns Hopkins, right? And it was an aha. So we got a phone call from the Michigan Hospital Association, who created a safety center and said, hey, our members know these infections are a problem. We want to do something, but our docs said they want to do it in a scholarly way. Would you be willing to work with us? And I said, well, sure, we're not a consultant. We're academic docs. We've never done this. Let's see if we can get a grant. So we applied to AHRQ, happened to have a grant, and we got funded to put this program in the whole state of Michigan. We, fascinatingly, we organized it where the State Hospital Association managed it. So my team at Johns Hopkins did what I would call the technical work. We developed measures, we developed a database, we summarized the evidence, but we said, I don't know how a rural hospital in Michigan works, so you take this evidence and put it as you know best. Again, we sought that sweet spot to say, locally adapt how you put it in, but don't change what you do. The evidence is the evidence. So whether you're in a 2-bed ICU in the Upper Peninsula or at the University of Michigan, every patient's got to get these 5 things. We're not giving on that. But you tell us how that you have to make that happen. And we got all the hospitals together. That we met twice a year to work on this project. We had bi-weekly conference calls where we would coach them, and then they would share, again, making an efficient knowledge marketplace. They would share what their struggles are. They would share what they're doing. We actually had, remarkably, the mother of the little girl came and gave the kickoff for this. And what we told the people was that success isn't if one hospital gets their infection rates down. Success is the rate of infections in the state. Because again, I'm a public health person, fundamentally believe in my heart that the citizens of America have a right to safe health care, that my mother should not shop around for who's not going to infect her or cut her leg off, that should be, with our resources, an expectation of the U.S. healthcare system, that anybody can go into a hospital and compete on food if you want, compete on maybe some high technologies, but safe care is a right for our citizens in the U.S. And so we reported individual measures, their infection rates, but our global measure was the rate of infection in the state. Again, we educated them on these 5 things. We put some programs together to help the doctors and nurses together work as a team because that doesn't happen very often. And so the nurses would question the physicians using this checklist. And it was phenomenal. When we first put it in, we said to the nurses, we want you to question the physicians using this. And the nurses said, I literally caused World War III. My job is not to police the doctors, and if I do, I'm going to get my head bit off. And the doctor said, there is no way you can have a nurse second-guessing me in public. It makes me look like I don't know something, to which I say, welcome to the human race. We all don't know things. But nobody debated the evidence. It was power and politics that kept us stymied. And so we transformed the debate to make patients our North Star and pulled everyone together and said, is it tenable that you harm people with these infections? And of course, everyone says no. And I said, then how could you as a nurse see someone not wash their hands and sit there silently? We can't afford to play like that. At the same time, you can't get your head bit off. So docs, let me be really clear. Unless it's an emergency, the nurses will question you, and you will go back and fix the defect. And if you give them flack, nurses page me any time of day or night. There's no discussion. You will be supported. Period. We have to make a healthcare system that reliably gives patients these evidence. And interestingly, when it was framed as that way, I've never been paged because the debate went away from who's right in power to align for the patients. The results are nothing short of breathtaking. We eliminated or nearly eliminated these infections in a whole state within 3 months. I mean, it's unheard of the magnitude of the improvement that we just are analyzing our 4-year follow-up data, and it looks like they stayed this low. The results of this are estimated that we save the state of Michigan per year somewhere around $200 million a year and about 1,800 deaths a year from this sole intervention. And we made a very public safety scorecard that we presented with the governor, some of their congressional representatives, to the public when this project was done to say, here is the safety scorecard. Any hospital can get individual hospital scorecards. Here's how we did here's our infection rates. Here's how often we're using evidence-based intervention. So this is that 2% improvement in process measures that I mentioned earlier. We went from 66% to 95%, right? A heck of a lot more than 2%. We improved their culture using a survey tool to measure culture dramatically. Now, what's frightening about this? Well, the frightening about this is I don't know if you went to this, but Congressman Waxman had a hearing about the U.S.'s responses to these healthcare infections that I testified for, earlier in the summer, I think. And one of the conclusions was that there's inadequate federal coordination on this efforts. And again, my kind of this idea of a knowledge market is really key. So he and his staff surveyed all the states to say, hey, there's this great thing in Michigan. It was funded with taxpayer dollars. Are you using it? What's going on? And he just posted the result. There's the website yesterday, I think, or the day before. And the conclusion, and we asked them, do you know the rates of your infections in your state? What are the rates, and what are you doing to reduce infections? Now, as you can imagine, when you get a letter from the Government Oversight Committee, the state hospital associations were quite interested to respond, and most of the letters were about 30 pages of what they are doing, right? Just the same thing I started to Sorrel King was. Only 8 of them knew what the rates of infections were. 8. So it's hard to know if you're making any progress. They certainly can't answer that young mother's answer because they don't know their rates. They all say they're doing a lot of stuff, and they may very well be, but I believe the public deserves better. And none of those 8s, none were anywhere close to as low as Michigan was. Right? And you say, why isn't this thing funded by taxpayer dollars a national program? Indeed, it's interesting. Our research group has just partnered with the World Health Organization, so we are putting this program in Spain, England, and Ireland as a whole country effort, working with their ministers of health to put it in. And quite frankly, I sit there a bit embarrassed to say, okay, why is it that these other countries could put some, a federal effort in or a large effort in, and we're not making progress in the place that did it? So what might be some thoughts of federal solutions to some of this stuff? Well, that translation superhighway that I showed you, I mentioned how it's an exceedingly inefficient marketplace because what happens is we fund basic research and some things lead to therapies, but frankly very few. And then some of those therapies, again very few, get actually put into practice and some improve health. And that feed-forward system is very good at identifying new knowledge. It's not very good at improving population health. And what I firmly believe that we need to couple that feed-forward system with a feedback system, which is what we did in Michigan. We'd say, what's the problem? They say people are dying from these infections. We said, okay, what's a program that we can put in to make those infections go away? Okay, well, there was this model at Johns Hopkins that's put it in a whole state. Now, as part of our work, we also uncovered shortcomings in effective therapies. We need new effective therapies, but we're driving those therapies by what the community need is, not necessarily by just trying to find new knowledge. And that shortcomings of those therapies can then drive some basic science need, but it's a much more structured approach to improve health. And we likely need a balance of both. Right now, our system is completely feed-forward. Second is that there's virtually no investment of the basic science, what I would call the basic science of patient safety. That the fact that we cannot give that mother an answer to how safe we are. And the National Healthcare Quality Report's conclusion is that there's just inadequate measures of safety is, in my view, completely unacceptable. I mean, we could measure brain blood flow, right? We could measure gene microarrays. We could measure safety. We just haven't invested in it. I mean, we need to invest it. And one of the things that we ought to do is, we spent about $3 billion on the Human Genome Project. And we're now reaping the benefits of that. But what was that program? That was a program that connected, I think, around 18 or 20 research centers around the country to pull the best brains together to tackle the problem, right? And they sequenced this ridiculous number. I think it's like 3 billion genes sequences to find these genes that are now the targets of therapies. We need the same thing for patient safety efforts. Now, let me give you an example. So the Joint Commission that regulates hospitals, and we could debate how well they do that, it's a different discussion, requires that we have to look at safety or harm from anticoagulation. Those are blood thinners that is a common cause of harm. But there's no national measures of harm from blood thinners like we have from bloodstream infections, right? One of the reasons why we can measure bloodstream infections is that there's a federal agency, the CDC, who made standardized definitions. Hospitals have infrastructure, people to monitor them. But outside of infections, it's the Wild West. We don't have any infrastructure to measure these harms. So I'm leading a group at Johns Hopkins to try to develop measures from them. My colleagues at community hospitals and at Harvard and at UCSF are all doing the same thing. And if you think about it, what a ridiculously inefficient system. Why don't we have a structure to pull people together to say, here's how the country's going to measure harm from anticoagulation, right? And we ought to be held accountable, but there's no vehicle to pull those people together yet, and we need the human genome equivalent. And the last is that we need to be able to train more people like myself who have approached this in a scientific way. I have a doctoral degree in clinical research, but I had to jury-rig a program training to how to find effective therapies, right? So I was viewed as a clinical trialist finding drugs, and because I had free tuition, literally created my own program of how to apply this to safety and quality. But there's no training programs. There's a lot of training programs if I want to study genes, if I want to study drugs, but there's virtually none to find effective therapies. And there's absolutely none to provide for people to be mentors in this work. Unlike in the basic sciences where you can get support through NIH to provide time to grow junior faculty to do this stuff. We don't have any. So I'll end with this, finding the sweet spot of simple and elegant. I love this study. In the Netherlands, they were having a problem with men aiming when they were going to the urinal. It was a very expensive public health problem. So they did a study and found that when they put a fly in the urinal, men were 4 times more accurate than there was no fly, right? Only in the Netherlands would they actually study this. Substantial cost savings. So they implemented a policy to paint flies on every urinal. And I was over in the Netherlands a bit ago because they're going to put the program in nationally. And I have to confess, not only are they there, but they work. It was like I was compelled to aim at it. And that idea of finding the sweet spot of these simple, elegant solutions, like our checklist, we really need to do more of, because at the end of the day, I think we owe this little girl's mother an answer of how safe our U.S. healthcare system is. And right now, we can't give her one. I thank you, and I'm happy to take questions. Sure could. Questions?
Last December, there was an op-ed in the New York Times about your Michigan study and how the HHS Office of Human Resource Protection had pulled the plug on you.
Yeah. I sure could. So luckily, we've made some progress. So what happened? When we started the Michigan project, I submitted the program to the Johns Hopkins IRB, the Institutional Review Board that reviews these things. And they said, because we're collecting de-identified data and this is quality improvement, it's exempt from research, go do it. And we did it. After we published it in the New England Journal of Medicine, and I think in response to some anonymous complaint, the OHRP, the Office of HHS that oversees protection of subjects, said that they disagreed with how Hopkins interpreted it, that we interpreted it wrongly, that we should have gotten consent from patients, that every hospital in Michigan should have gotten IRB approval. And I'll tell you, 60% of them don't have an IRB. So this product would have never happened. The clinical community exploded because they just said, that's nuts. I mean, you got to get consent to ask doctors to wash their hands. Doesn't, and all the data is completely de-identified. I mean, literally the data elements we collected were number of infections, number of catheter days, no name, no nothing. And it caused an enormous uproar. But what it really pointed out was that there's too much lack of clarity in the regulations. I mean, it's not like Johns Hopkins IRB is not sophisticated. We review thousands of protocols. If a sophisticated IRB could, in the regular's mind, go that wrong, it says you got a problem with your regulations. You got to tighten them up. One of the things I'm delighted about is we've been working with, and I've been working quite hard with the acting director of OHRP, Ivor Pitcher, because I called him and said, Ivor, this isn't going away. That what worked in Michigan, morally, we have to put in other states. And I'm working to do that. But I don't want to be held accountable after the fact that you think we interpreted these things the wrong way. So would you please give me in writing what standard you're going to hold me to before I go doing this? As you can imagine, there was some reluctance to do it in writing. I think luckily the Congressman Waxman's hearing turned up the heat to say, okay, this is an issue, we have to solve this. And luckily we just got, at the end of July, it's on their website, a letter that essentially said, this isn't research, you don't need consent, you don't need IRB approval, go ahead and do it. But your original thing in Michigan still did.
Hi, I'm Rush Holt, representative from New Jersey, and as some of the audience know, co-chair of the Biomedical Caucus. Thank you very much. I just wanted to say a couple of things about Dr. Pronost's presentation. I'm sorry I came in late, but I did read the New Yorker article months ago, and I gave it to my wife, who's a general internist and a medical director of a clinic. So it illustrates several, I think, important points, and that are at the heart of the reason for the Biomedical Caucus. One is that research can take all forms, and although you don't want the IRBs to be calling this research, so you don't have to get the approvals, nevertheless, it is research in the sense that you're thinking like a scientist, you're asking questions that can be answered empirically and verifiably. That's science. The research takes many forms. And NIH actually supports research of many kinds, but it doesn't have to be using polymerase chain reactions in order to make medical advances. Which is the second point, is that we really need to impress on your bosses and others here on the Hill that research and providing funding for researchers is not a jobs program for people in lab coats. It is really about improving the quality of life for Americans. In this case, saving lives. And that's often lost. So many of your bosses see researchers as another interest group. And we have to get beyond that. This is fundamental in any area that we're interested in, whether it's transportation or energy or healthcare. We are underinvesting in research. And that applies to the National Science Foundation and NASA as much as it does to NIH. So, I think Dr. Provonost is a particularly good, is this the last, by the way, the particularly good capstone to a series of very good programs, and I hope many of you have gotten to hear many of them. Because I think his presentation makes these critically important points, which are central to the existence and the purpose of the Biomedical Caucus. So thank you very much for your presentation.
And I think this is, we absolutely have to fund science more. I mean, there's enormous data that there's economics benefits and there's a moral imperative of improving lives. Thank you.
In Michigan, did you have hospitals that perform less well than hospitals that perform better and things like that, where there's some fine-tuning like that?
There absolutely was. And what we did was, in the beginning, there was variation in who got it and who didn't do it. And again, one of the things that we push back is to say success is when the citizens of Michigan have safe care. So we buddied people up and said, your rates have gone down. You call the hospital and share what you did, see what you can teach each other. And you would have thought, especially in tight markets, people wouldn't do that. But the reality is they really did, because when you present it like this, you shouldn't be competing on these infections. And so they worked with each other, and now virtually all the hospitals, well, all their rates came down. Not everybody's zero, that's the median rate, but they're all at below the 10th percentile of the country.
Yeah, I have two questions related to money. One, and you may have said it during your talk, but I was so blown away by the results you were getting that I forgot, is what federal funding did you have? And then the second piece is, first of all, congratulations on your Genius Grant. And hopefully, you know, if a painter gets a Genius Grant, they probably buy paint or, you know, whatever. But hopefully you're not going to have to use your money in lieu of, you know, federal funding or funding from Hopkins or, I mean.
I'm not sure about that.
Well, tell us what you're going to do.
So let me talk. The grant was from AHRQ, and I told you we saved about $200 million a year. Mm-hmm. It was, and I don't want to quote me, but I think it was around $500,000 a year for 2 years. So $400 million return for about $1 million investment. And of that $500,000, about half we gave to Michigan to coordinate the program. But one of the great points that you made is our team approaches this quality and safety just like we do drug development. So you know in drug development you have phase 1, you do basic research, phase 2 and phase 3. So we take programs and do the technical work in the same way. So for instance, we're looking now for funding to say, okay, MRSA and VRE are huge problems. We're talking a lot about it, but we haven't really done much. So how do we measure that in a scientifically sound way? What's the evidence? And can we make checklists to summarize the evidence? And let's pilot test that at 1 or 2 hospitals like Johns Hopkins. When it works, let's package it in a scalable way and make it publicly available to the country, right? And that kind of pipeline development is absolutely critical to say, okay, let's package programs, at least the science part of it. Sure, local hospitals vary on what their resources are and what their culture is to put it in, but there ought to be a funding to produce these programs, and frankly, there is none right now. I mean, so I think funding that pipeline is absolutely key, and it requires us to work with the clinical trials to say, okay, here's what we know about the evidence, here's how we know how we measure it, and put it together into a program. What am I going to do with the money? And I mentioned earlier the similarities between the financial crisis. So one of the things that we've learned, and I made this analogy, is that a fundamental problem is an inefficient knowledge market. Right? So you go to your doctor and you may get evidence half the time, but somebody knows the right things. And the flurry of second opinions that go on in healthcare is essentially a reaction to say, I'm not sure the doc gets it right. We developed one checklist as a way of democratizing knowledge or making a more efficient knowledge market. But there are 15,000 diagnoses and 5,000 procedures. And all of them need a checklist, right? And one way of efficiently making checklists, I don't know if any of you read Jim Zerwicki's book, The Wisdom of Crowds, but his book is based on the tenet that markets or the community has knowledge, that if you can tap into it, they typically understand things and they'll get it right. You know, and the stock market is a classic example of the price of a security is typically based on the knowledge that's available. And when it's erroneous, you have booms and busts, right? So you have the tech bubble or you have what we're dealing with now. And I believe fundamentally that there's certain markets in society, like a mortgage, like your retirement, like healthcare, like saving for your kids' college, that we have an obligation to make sure they're efficient. That we have to make sure that when I go to get healthcare, I'm getting all the knowledge that's represented out there anytime. And a way to do that is by summarizing them in checklists. But if I were to make a checklist for 15,000 diagnoses, I'd be long dead before I got to 1,000. So what we're working on is to say, could we make a checklist maker? Right? So how do I create a checklist maker that we would say, okay, you go for diabetes or sarcoid or buy a mortgage. What are the 5 things that are most important for me to know about that? From my perspective as a consumer, right? Not when I'm getting sold a bill of goods from someone telling me I could afford this, but from a consumer's perspective for these things. So let the markets work because there's pretty good data that markets do work when they're efficient. We get into problems when they're inefficient. So we don't necessarily need to overregulate. We need some regulation, but we have to make the knowledge for some of these things available. So we're working with or looking for support to partner with our informatics, and I'm not at all an informatics person, but the clinicians to say, how do I create the plumbing that I don't have to go one checklist at a time, but I just create a way to make checklists and let the diabetes doctors, let the orthopedic doctors, let the patients with orthopedic injuries all put to say, here's what the evidence is that I want to get. So when I go to my doctor, I know I'm getting what the best evidence is. I mean, and it's a transformative idea for healthcare because it's been so that feed-forward system, and this is disrupting that. So that's what I'm hopefully going to work on.
Peter, talk to us a little bit more about markets. How do you market what you've learned here? How do you get other states to adopt it? I mean,
Right.
do you go through the hospital associations and the doctors associations
Right.
and all, or do you?
Right. I mean, so I think that's exactly right. It's exactly right. One of the reasons why I really liked what Congressman Waxman did is I think, there was, when they were surveying hospitals, the first question that they had on the survey was, are hospitals using their checklist? And I pushed back on them and said, that's the wrong question. They're all going to tell you, yes, what government oversight should be, hold them accountable for the rates, right? You measure your rates. Don't get involved in the practice of medicine. Let the science evolve, right? Let the market of that knowledge mature, but they ought to be measuring them and they ought to be low, right? And so they changed it, and everybody said they're doing it, and only 8 are doing it. So I think my approach is to pull as many levers as we could. So I think there is a regulatory approach. I mean, I think it's an abomination that states don't know their rates of infections. They ought to. And by doing that, then it could be hospitals have to work on things, or if their rates are high, they shouldn't be paid for these infections. One of the things that, as you probably know, CMS has a new policy of not paying for preventable complications. And I wrote a commentary in JAMA about the wisdom and justice of that policy. And as you might imagine, strongly support the concept, but have great concerns because the politics is way ahead of the science. That is, outside of these bloodstream infections, we don't know how to measure, or we don't know if the other things are even preventable. I mean, there's so much error in that it's more likely to be gained. We have to invest in the science. When the science is good, like these infections, don't pay hospitals. I mean, they absolutely shouldn't be paid. But we don't need to start with 20 things on the list. Let's just lick this one problem. This polio used to kill 350,000 people, and now it's virtually eliminated in this country, and almost worldwide there's a few hundred cases. Safety, or the U.S. healthcare system needs our polio campaign, and I think these type of infections are the test case, because not just will you save these lives, but we'll learn how to work together. So this is going to require the CDC to partner with CMS on payment policy, right? And regulators and state hospital associations and professional societies and docs to all work together and say, how do we lick a problem on a big scale? And once we learn that, then let's build capacity to go on and tackle the next problem. But when we try to get unfocused, and our aim gets off, right? We need the fly in the urinal. Focus us on a problem, and let's get a win and reflect on, okay, here's what the role of congressional oversight is in this. And yes, we get it wise. Here's the role of hospital associations. Here's the role of docs. Right now, we got a lot of people talking on it, but I'm not sure who's accountable for this, right? It looks like federal government doesn't really have oversight. The states, based on the results from the Congressman Waxman survey, doesn't look like they have oversight. And the hospitals don't look like they're doing much. So I think we need to say, okay, who's really responsible for this, and how do we work together to drive real improvements, not just political improvements.
Do you know whether the general move of the last X decades to get patients being more proactive with their doctors has actually worked in very much of a proportion of the population or their interaction with doctors? Because you're saying that NIH should get itself more into translating these things. There are some areas, such as the Back to Sleep campaign for SIDS, where they've done a lot of that, and they do a lot with cholesterol education and all of that. Back to Sleep is aimed at parents in addition to nurses and coaches and this kind of thing. So if you could get the thinking public, the consuming public, more aware of things like hospital infections, maybe they'd open their mouths and say, hey doc, did you wash your hands?
Yeah, I completely agree that there's some evidence that when you publicly report outcomes, patients use that information, but it's really, the evidence isn't so strong. But part of it is, I think, a failure of us as researchers to make that data digestible to the lay public. And it's funny to say because one of the ahas that I had about checklists is one of their main things is they democratize knowledge, or perhaps they make it more efficient. So what do I mean by that? Well, with our own cultures, doctors could call fast breathing tachypnea. Nurses call it labored breathing. Patients call it I'm just short of breath. We're all talking about the same thing, but we talk past each other, right? What do we do in these checklists? We made them behaviorally specific, but lay language, right? Wash your hands. So now I hope, and I don't know if you saw Jane Brody wrote a column about this checklist called A Call to Arms. I hope consumers come into hospitals and say, here's the checklist about these things. I understand it. Wash your hands. Are you using this soap? Did you gown? And we partner with communities because I think once you view patients as your North Star, then we're all in this together to make sure that everyone gets what is the best care that we know possible in saving lives and saving dollars. And I think this idea of simplifying evidence into these checklists are a really key strategy.
So this makes so much sense.
Why aren't other state doctors and hospital associations knocking down your doors to replicate what happened in Michigan?
Yeah, it's funny. So, I mean, in some sense they are. I'm an academic doc, so I live on grants and clinical practice. So our cost to put this in a state is somewhere, depending on how big this state is, somewhere around $200,000 to $250,000. Again, we don't make profit on it. That's just to cover my time, staff time, statisticians to analyze the data. And some hospital associations, that's a big enough barrier. Even though there's an economic return, the return isn't to the state hospital association, right? And so some of the question is who's going to fund this? Some states have been looking for local philanthropy to support it. But it's one of these, an inefficient system that if we knew we'd do this, maybe the payers in that state. So for instance, we put this into Rhode Island, exact same results in Rhode Island, and the insurers paid for it because they said this is a no-brainer. I mean, I'm getting... in Michigan, Blue Cross Blue Shield has continued to fund it. But part of it is who's that convening group to say, okay, we have to do that. And I think we need to understand why this isn't happening because there's this ironic thing is when you said this is a no-brainer, there is not one person who hears this story who said, don't do that. I mean, it's common sense to the patients, it's common sense to the public, the payers, the docs, the hospital association. It's just, okay, where's the leadership to pull this together? And we've been selling this state, so we just started West Virginia, for example. West Virginia said, we get it. They got a grant. We worked with them on how to get some insurer support. We're working with Sherrod Brown to get Ohio to do this, to get one of the foundations there to try to support it. But it's a slow process, state by state by state. But, I mean, it has to be done.
I was wondering if you could talk about, following up on that, whether it has to be states, and sort of based on your experience in Michigan, what's the best kind of organization to be working with? Whether you could be doing it at city or insurers that are cross states?
So great question. We just put the program in, and it'll be published shortly, in the Adventist health system, and got actually even better results than Michigan. The rates went down to point, I mean, like unheard of. There's virtually no infections. And we debated a lot of what's the right distribution channel for quality and safety programs, right? And so that, I mean, I really think about it as a distribution channel. The problem with using large health systems is half the hospitals in this country aren't part of it. And the rural hospitals, or the small ones, may be the most resource constrained in needing this. I don't know if I'm right. My belief of state as the distribution channel was one, an efficiency, that it's a big enough chunk that it's doable, and that people care about their states, right? There's organizational structures that we can tap into, like state hospital associations, where not every city has one, so that we could leverage existing infrastructure to organize these products. And I think accountability mechanisms that they ought to be doing this. There's the QIOs, so the CMS quality organizations typically organized at a state level. There's insurers organized at a state level. So I'm open to think of other things, but right now that seems like both the most efficient and effective way for federal agencies to say, fund the science, right? We'll fund the technical program out of federal dollars. We'll get the evidence, we'll get you the measures, we'll get you a database. Now states, you take that and you in your state decide how you're going to do it. But we will hold you accountable for measuring and reducing these harms. And I think that model fits with a decentralized, giving flexibility to the states, yet holding accountable is my own vision. Other questions?
You mentioned CMS several times, or TMS. What is that?
Oh, Center for Medicare and Medicaid Services, the branch of HHS. It's the largest payer for health care in this country. They purchase health care for the elderly, the disabled, people with chronic renal failure, and they support about half of the Medicaid program for poor people in states.
Since we're in a congressional building, what would be your ideal action from Congress to help support what you're doing, or help support other researchers to improve upon healthcare?
Yeah, exactly. I think we absolutely need more funding, and one very concrete proposal would be to create we have to learn how to do this wisely and scholarly. So to fund something like the Human Genome Project for patient safety, right? And it could be coordinated through AHRQ or NIH, but say, let's pull researchers like myself together, say, what are these? How do we know how to reduce costs and quality and save lives and substantially increase that funding? I would dramatically improve funding to train people like myself. I mean, I'm the rare bird who has methodologic training as a physician in quality and safety. I mean, they just don't exist because there's no programs for it. That pipeline needs to start, but that's a 5-year to 10-year investment, right? I mean, I think we need to do something sooner. And what I would do, which would be a very concrete thing, is CMS said they're not going to pay for 8 or 10 things. And I think many of those we don't know how to measure, they're preventable. One very concrete thing would be to fund this human genome equivalent, and for those 10 things, actually develop valid measures and prevention strategies. So we're not just penalizing hospitals for not doing it, but that we bring resources that actually improve care, right? So why not say, okay, you did this for one of those bloodstream infections, now let's make sure there's the same type of programs for all those other 8 things, and whether it's housed under AHRQ, whether it's housed under an independent institute, I think that could be decided, but that there's science to match the politics, because right now it's a lot of politics and very little science, and the fear is we will do nothing to prevent needless deaths if the science isn't there. I mean, hospitals will do things, but it'll be a sham. I mean, and I think this little girl's mother deserves better, that we have to do that. So that could be a very, I suggested language for that in this authorization bill where Congress is saying we're not going to pay for these things, to say, okay, well, where's the science to match that payment structure, right? Okay, the payment is great, but there's no investment in the science. Here's a chunk of money that we will say we'll develop measures, we'll have, the output is a program that can go state by state, publicly available with taxpayer dollars to improve each of those other things. And that, I think, would be probably do more to save lives than the last 30 years of funding that we have done. All right, well, I thank you all very much.